If we could record the meeting.
Yes, you can do that.
Thank you.
Okay, so for our first micro course, you will have with me three micro courses. The first two, this one about the orthopedic examination. Tomorrow, we will have a micro course about the treatment, the basic, of course. We will not discuss all the treatment that we can do in orthopedics, but the basics. And the last micro course that we are going to work together about is the recapitulation. We will discuss and see a lot of X-rays and we will speak exactly about them. Of course, all of this is much easier done when we see each other face to face because we can interact much better and we can, and you also would understand a lot better, I think. But we will do as much as we can with this type of presentation. As you learn from the major course, you will come to the hospital, but not all of you at the same time. And in that time, you will see and we will discuss about different pathologies.
Are we gonna start coming to the hospital after the vacation?
I'm not exactly sure. I asked the guy that was in charge, but he didn't tell me. What did the professor tell you at the course?
We didn't ask. We'll
You
just
didn't
ask
ask.
tomorrow. Yeah, they told us that we're gonna find out today. Yesterday, sorry, I spoke with Dr. Cursaro,
Yeah.
and he told me that he's gonna let me know yesterday, basically, but he didn't tell me anything. So I don't know. I think I'm just gonna send him another message and see.
After you, yes, after we will finish this micro course, you will remain online for 1 to 2 minutes, and I will call again and I will tell you exactly. Okay?
Okay, perfect. Thank you
So
so
we
much.
know exactly how we have to do it. Okay.
Thank you. Thank
So
you.
let's get started. About the orthopedic examination, as you have learned from all your other stages and any other specialty that you have made until now, the examination is very important because it brings us a lot of information. I'm not speaking very fast right now because I'm trying to send a message to somebody to inform them and maybe have the information until I'm done with the course. So just 1 second and then I will continue. Okay, so as I told you, the examination is the most, not maybe the most, it's too peculiar, but it's very, very important to us because it brings a lot of information to us that can help us to diagnose and, of course, understand the pathology and then treat it. In orthopedic surgery, mostly in traumatology, because in oncoskeletal treatments it's a little bit different, but in traumatology, just an examination and an X-ray in 80% of the cases is just enough. A lot of fractures have a pathognomonic position or something that is very peculiar and specific to them. And just by speaking with the patient and then seeing him and making an X-ray is just enough to understand the pathology. Of course, that's it in the most cases, but not in all of them. So, first of all, what's the most important thing? We have to question the patient, as I told you, about his complaints, about his history, and his family history. The complaints can be subjective, okay? So we cannot be, we can't believe everything that the patient tells us. So we have to extract the information that we need to see how he manages the situation and understand what his pathology is. But just his complaints are not enough to make us know exactly the pathology that we are seeing. Of course, we can investigate further and have information about his history. On the slide, it's orthopedic history, but not just orthopedic history. We are interested in anything that happened to the patient. If he had any other types of interventions, any types of fractures, any types of pathologies in the vascular system, the cardiopulmonary system, the digestive system. This is also important for us because some pathologies in the cardiovascular system, for example, the atrial fibrillation, for example, if a patient has a lower limb fracture and atrial fibrillation, this will increase his risk to develop a thrombosis. So we have to keep this in mind. Or maybe he has a insufficient cardiac force. So his normal cardiac beatings are not enough for him and can bring also some problems when we want to operate him. And of course, the family history is very important too, because some congenital pathologies are kept in the family, so to speak. So it's important to understand and know if the patient has some rheumatic pathologies, some oncologic pathologies, or something like that. After we spoke with the patient and understood what he has to say and seen exactly what his complaints are, it's very important, as I told you, to make a general examination. Why? Because this examination will bring us information that we see with our eyes and understand with our mind. So it's a thing that helps us understand the patient better, and it's not subjective by the patient, it's subjective by us. So it can help us a lot in the treatment of the patient. Very important during the general examination that implies every segment of the body. It's very important to see, of course, the musculoskeletal part, because that is what interests us the most. So that's what we treat, but we have to keep in mind every other aspect. So, of course, we will see the movement of the joints, we will measure the length of the extremities, we will see if there's swelling or other things like that, crepitations, pain, palpation and stuff like that, that will help us understand the pathology. Of course, palpation, that is normal in any examination. Percussion is not so important for us because we cannot do this in any segment. We will determine the muscular strength. This is important because, first of all, we will see with what the patient begins and how he will evolve in time after our treatment. And second of all, we will understand if he has any neuromuscular disorders that can bring a problem to our treatment. If there are any functional disorders, of course, and we will use additional methods of investigations to understand exactly the pathology. I will give you some examples in the next slides. What are the complaints of the patient? Of course, in most of the cases, 90% of cases, the patients will come because of pain. Okay, you will see, as you saw until this day, that a lot of patients sadly come to our hospitals, not only in the orthopedic part, but in others too. They come too late. Okay, so they have some pain, they have some swelling, they have some problems, but they don't come directly to the hospital, but they wait and they come too late. But in most cases, pain is the first thing because nobody likes pain, and when they feel it, they come to the hospital. The next thing is the limb length discrepancy. Okay, so this can come from different types of pathologies. It could be a congenital, if you have a congenital shoulder, for example, or he has a neuromuscular disorder and he has some muscular contractions, or he has a fracture that didn't evolve correctly. It's a arthrosis or a callus viciosus, and then again this can go to a shortening of the limb. Mă scuzați o secundă. Sorry for a second. Alo? Da, am văzut, poate să plece, da, sunt cu studenții la examen și nu pot scor bine, mersi mult tot. Okay, so again, another important thing is restriction in movement. This can appear again in a lot of pathologies, for example, in gonarthrosis or arthrosis, when the movement is smaller, or for example, in the fracture of the hip when there's no more movement. Swelling again. And if we speak about trauma that is more important than just from a fall, for example, a traffic accident or something like that, we can have defects of the soft tissue. And through traumatism, we can have, of course, the loss of function. Anamnesis. This is very important because we learn about the patient. In cases of the orthopedic injury, you must determine exact data and time when the accident has happened. Why is this important? Because exactly as I told you 2 minutes ago, when we have, for example, a traffic accident, okay, so a high energy trauma, and maybe the patient has external bleeding, acute external bleeding, and the ambulance or somebody that was first there did a garo, a tourniquet on his segment. This can be very problematic if we don't know exactly how much time it was on that segment. Okay, so the tourniquet must not stay more than 1.5, maximal 2 hours. Why? Because the destruction of muscles and most of them nervous tissues appears very fast. Okay, through this hypoxia, yeah, because that is the biggest problem through this tourniquet. Will destroy the vascularity of the nervous system that can lose its function in time. So that's one of the examples that why anamnesis is very important. Life history, as I told you, it's also important to understand if the patient has any pathologies in his family that are important for us and that can change our treatment. Of course, abnormal position, this is an X-ray an X-ray and a patient that can be seen very frequently in the emergency room, the fractures of the hip. If we speak about the neck of the hip or the peritraumatic region, these are very, very frequent in elderly patients, but also in younger patients, but through a more important trauma. And this pathognomonic position of the lower limb is very suggestive to this pathology. Okay, so when we see a patient that has his lower limb in external rotation, abduction, and abduction in the proximal part and abduction in the distal part, then we will always think about the fractures of the hip. Okay, I will not explain to you more about these pathologies because you will see them and you will discuss them in the courses about the lower extremities fractures and the upper extremities. Okay, you have 2 courses for lower and 2 courses for upper, and in those courses they will explain to you much more about this. I am just saying about that. I'm just telling you a little bit so you can understand and see a little bit how we should see a patient and understand his pathologies. Next, the measurements of the limb. Okay, first of all, we have to understand from which point to which point we have to do these measurements. As you can see in these images, they are very important. First of all, to see exactly the length of the limb, but of course, it's also very important to see the deviations of the limb in valgus or in varus. Much more important and easier to see on the lower limb. And it is very important, as you can see in this image, when we do an X-ray of a segment that has problems, always keep in mind that we do not do a image just of the exact segment when we speak about the lower limb. We have to do a pangonogram. This is the name of an X-ray that sees the whole limb. This is very helpful because, for example, this is a better example because we use it more in gonarthrosis. For example, if a patient has this type of gonarthrosis, we have to do the pangonogram so we can see the hips, because in most cases, the patient has problems also in the hips. And if the coxarthrosis is also important, it's better to begin the operation with the coxarthrosis and then go for the gonarthrosis. That's why we have to do a pangonogram to see exactly the level of injury and the extent of it. You can see here in this image a fracture of the tibia. Most of these fractures come through direct traumatism. As you can see here, it's a transverse fracture. You will learn, again, I will not go in much detail, you will learn exactly about each type of fracture, how they come to be, how they are, how they evolve in time. So you will learn all of this in the courses. But this is a fractures of the tibia. This is also a very frequent fracture that comes to when the patient, for example, is on the crosswalk and the bumper from a car hits the patient's in tibia and does this type of fracture. Because the energy of the trauma is high, of course, the fracture is not the only thing that the patient has. He will have a destruction also of the tissue, the subcutaneous tissue, the skin, the muscles. Okay, and through this, if the patient doesn't comply and goes with the treatment that we tell him, or if we make a mistake in the treatment, it can evolve in this type of pseudarthrosis, as you can see, with a valgus deviation of the tibia. Okay. Another example of clinical measurements and how they help us, as I told you earlier, is the effect of the knee joint, the gonarthrosis, as you can see here. This is a gonarthrosis in a very higher stage. Okay, so the destruction, as you can see, is very important. We don't have any more articular space. We have a deviation in valgus, as you can see. So a very important destruction and disruption of the segments that have to be kept in mind when we will do the treatment. After we have made the examination through the X-ray and seen the patient, it's very important to see the range of movement of the joint, okay? So we can understand how much of the cartilage and the articular surface is destroyed. You have to understand that we discuss about two different things. It's the active movement, one, and the passive movement. The active movement is what the patient can do when we tell him to do it. So we can tell him, extend your hip, extend your knee, flex your hip, or something like that. And we will see exactly what degree he can do this. And the next thing is, after we will put the patient on the examination table, we will do the movement with our force, so the patient will stay without his muscles contracted, and we will mobilize the segment in different types of movements. And through this, we can assess different pathologies. Because, for example, if the patient can move in the knee just, for example, 30 degrees, and after he moved this 30 degrees, we can move the knee to 70 degrees, for example, then we will understand that the pathology is not only in the articulation, but rather also in his muscular system. So he doesn't have the force to do the movement, but the articulation can do that movement. So we'll have to have this in mind. Of course, if we speak about a patient like this one, he will do 20 degrees active movement, and also the passive movement would be again just 20 degrees, because there isn't any more space. That's the problem of the patient, not the muscular part, rather the destruction of the articulation. We have to understand these 3 degrees of stiffness. First, we have the ankylosis, when we don't have any more movement. So this is a ankylotic knee. Okay, so this is ankylosis. When we do not move, the patient can't move at all. We have the contracture. So the patient cannot move because he has a contraction in his muscles, but the articulation is still okay. And rigidity, the range of movement is less than 5 degrees. As you can see here, the patient cannot full extend his knee. He has like 20 degrees of flexion still. Of course, the movements that we measure are not only in the lower limb, rather also in the upper limb. The upper limb is much more mobile, as you know from yourselves and as you can see in other patients. This movement comes from two things. First of all, we have the glenohumeral articulation, okay, that does a lot of movement, but we have to keep in mind, but we also have the scapulothoracal articulation, okay? So for example, if we didn't have the scapulothoracal articulation, then when we will do abduction more than 90 degrees, it would be impossible. Why? Because at 90 degrees, the trocheter will hit the acromion, okay? So when we do abduction to 180 degrees, then this is done because of the movement of the acromion of the scapula on the thorax. You still can hear me, right? Because I had a problem some day, and that's why I'm asking.
Yes.
Yes.
Okay, thanks. The internet is not the best here, and we had some problems. So, okay, so you have to keep this in mind. So the movement in the glenohumeral and the upper limb articulation is so good and so with the important amplitude because of the two articulations, so to speak, in this region. Okay, it is very important to understand that maybe a stiffness in the lower limb is not so problematic as a stiffness in the upper limb, because the movement is not so important in the it's harsh to speak, but when you have, for example, a stiff leg, you can still walk on it. But if you do not, you have a stiff shoulder, it's very, very hard to do your everyday things. As you can see here, for example, in the first image that is in this corner, in the left upper corner, you can see that the capsula of the glenohumeral articulation is very wide and very big until the acromion. And any traumatism that is in this region will generate a fibrosis, and this fibrosis will slowly but steady block this articulation. As I told you, we have some images and some position of patients that are pathognomonic. As you can see in this one, the shoulder dislocation. Again, I will not discuss a lot of this because we have another micro course and a course about this. But I will tell you the most important thing. First of all, we will have this shoulder in epaulette. That's the name because epaulette is when you think about somebody in the army, about a general that has a lot of degrees in army, so he has done a lot of things. He will have this type of thing, a epaulette, so a thing that comes off his shoulder that shows how brave he was and how he has fought in a lot of wars and how he received a lot of medals. Okay, and that's the way why the name epaulette came to be. This is one thing, and the second thing, because in the scapulohumeral relaxation, most of them are anterior inferior. The head of the humerus will come in internal rotation due to the traction of the pectoral muscle. And you can see on the good shoulder, this is the deltoid muscle that comes from the clavicle and the acromial part. It comes and goes on the deltoid tuberosity. And you can see here the deltoid tuberosity is moved internally, so the deltoid is not so convex as normal. Again, very important to understand is the articulation of the elbow. This is an articulation that is composed out of three articulations. Okay, so we have first of all the humerus and ulna, then we have the humerus and the head of the radius, and then we have the radius and the ulna. The ulna and the humerus can do flexion and extension, and the radius head with the humerus and the ulna does pronosupination. This is also very, very important because, again, fractures and pathologies in this articulation will be very problematic for the patient. Think about yourself and how hard it will be for you to do anything. Brush your teeth, take a spoon and eat some soup without pronosupination. These are movements that change our lives, so it's very, very important to understand them and look for any deviation in this region. Elbow dislocations, again, the most frequent of them are posterior, as you can see here. Again, pathognomonic for luxation, you can understand, and if the patient comes with his hand exactly with the patient you see in this image, you will know that he has a elbow dislocation or a elbow dislocation with a fracture, but of course we will have the dislocation. So we have this in mind. Through the fractures of the radial head, you can see here that we can have small deviations in the articulation. Again, these are images just for you to understand these things. You will discuss and see a lot more of these images in our Word and in the courses and the micro courses that will come. The knee is also an important articulation that has to be well understood, because the knee works mainly in when we walk, and forces are applied on it. So we have to understand the structures that give the knee its movement and its resistance to movement when we have a traumatism. First of all, we have the collateral ligaments, the lateral and medial one, that gives us a lot of strength for the deviations in VAL and VAR. And second of all, that's also very important, we have the cruciate ligaments, the anterior and posterior one, that don't that keep the knee from moving anterior or posterior. And the third thing that is seen only in the knee is the menisci. Okay, the medial and the lateral one, they are very important because the knee works mainly when we walk. The forces in the knee differ greatly upon the forces that we apply in it. For example, when we walk normally, the forces in the knee are 1, 2, maybe 3 times our weight. When we walk on some stairs, it goes to 7, 8% of our weight. And when we run, to 13, 15, maybe even 20% of our weight. So you can understand that we have immense forces in this region. And that is why the menisci help us a lot, because they take a lot from these forces. The menisci are, so to speak, like a sponge. They take a lot of the force and help us not destroy our cartilage. Because if we wouldn't have this menisci, gonarthrosis will be very, very common in patients 20, 30 years old. Okay. Again, there is the image that you saw with the valg and the var deviations of the lower limb. Why does this deviation come to be? First of all, through destruction of the articular cartilage. So this is one. Second of all, because of the way the patient walks. Okay, so this is also very important, because some patients walk in valg or in val or external rotation, internal rotation. If you look on the street and see how the patient, not the patient, the people walk, you will see that each person has a different type of walking. So this is also a very important thing. Again, the weight of the patient, of course, it's also important if the patient has important development in the muscles or not. So if the patient is well trained, then the evolution will be not so severe. And as you can see in the image, in the first stages of gonarthrosis, this is not the first stage what you see here, but it's third stage, second to third stage. First of all, we will have a deviation in VAR or in valgus. Why is that? Because through the forces of the muscles and the walking of the patient, he will have a force that will apply either internally or externally. And if the forces are internally, then he will have a increased space, articular space externally, or vice versa when we speak about external compression. And this is important to understand for the treatment mainly, not only the surgical treatment, because that's the most important one when we have this degree of destruction, but also the kinetotherapeutical treatment, so the trainment of his muscles and the involvement in time of this hip, this knee. A very, 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 very rare dislocation is the knee dislocation. This dislocation must be kept in mind because it's very problematic due to vascular nervous system that is here. Because you know that everything that comes from the knee below comes through the popliteal region, as you can see in the X-ray, you can understand the forces that are applied in that region. The risk of rupture and destruction of the nervous system is very, very high. And the knee dislocation is, all dislocations are emergencies, but the knee dislocation is one of the most important of them. Of course, as I told you, because of the very important structures that give the knee force and resistance, it's very highly unlikely to have a knee dislocation. But in some cases, for example, in a rugby match, if a player that has 200 kilos hits another one with his shoulder in the posterior part of the knee, of course he will dislocate his knee. So we have to keep this in mind because this is also a very problematic pathology that has to be understood and treated very, very fast, because if it's not treated in the first hours, then the patient may lose his leg. Another thing that is also pathognomonic are the fractures of the patella, one, the fractures of the olecranium, and the fracture of the greater trochanter of the femur. We will always see this type of displacement. Why? Because in this case we have the quadriceps muscles and the rotulian tendon that will pull on the rotula, and of course if the fracture is transverse, it will mobilize itself a lot because of the contraction of the muscles. When we speak about the olecranium, we have the triceps muscle that is on the proximal pole of the olecranium, and again the forces will move this fragment. And also in the case of the trochanteric region, if you have a fracture just of the greater trochanter, the hip muscles will move the fragment. Of course, in the olecranium and in the patella, we will see this much easier because it's directly under the skin. We can palpate this also, for example, in the fractures of the tibia, the tibia malleola, but it's not so easily palpated as in the cases of the patella. Last but not least are the discussion about the movements of the hip. The hip is very similar to the glenohumeral joint, but it has an important difference. You can see here the acetabulum, different from the glena, is much more concave, so it can protect much better the head of the femur. For example, in the glena is like 1/3 of the head of the shoulder, and the acetabulum is more than 2/3 of the head of the femur. So it's much more harder to look, say, this type of articulation rather than the articulation of the scapulohumeral joint. But it can appear, of course, but in most cases, it's not just the luxation, it's also a fracture. Again, the luxation can be pathognomonic. You will learn about all of these luxations. There are four types of luxation of the hip. Two are anterior, two are posterior, anterior superior, anterior inferior, posterior superior, posterior inferior. Each of them has a different and pathognomonic image. Radiological and clinical, you will discuss them and see them exactly in the courses about luxations. But I've put these two images side by side because in some cases fractures of the hip can look like a luxation and vice versa. So you have to do an X-ray to understand exactly the pathology and be certain that it's a luxation or a fracture. Again, with the measurements are very important. One, to understand the pathology, and second, to know how to treat that pathology. Okay, because as you will learn in very big aspects, I'm not going to discuss about every aspect of this, but in greater regard, we have two types of osteosynthesis. We have the centromedullary nailing and the plate and screws. And of course, when we speak about centromedullary nailing, we will have to know exactly the length of the segment that we are going to nail, because if we don't know that segment, we cannot treat that segment. Okay, so this is another thing that is important for us. This is the centromedullary nailing can be applied for the femur, the tibia, and the humerus. We will not use them, or we'll use them very, very rarely in the antebrachial region because of the different type of bones and how they look in anatomy. Of course, when we do these measurements, we have to do it bilaterally because the musculoskeletal system is bilateral, and we have to see exactly from where the pathology comes. For example, in this hip, it could be a congenital hip, or maybe it has a contracture in the lumbosacral region, or he has a fracture. So different types of things that can be understood when we measure these two limbs separately and together. And it's also very important because, for example, if he has a shorter limb, it's important to use something to lengthen that limb, because a shortening will promote pain in that region. The limb length discrepancy can be real, anatomical, as you can see in this image when we have a fracture. So there's a fracture, as the video from YouTube tells us we have to fix it. So we have a fracture, and of course the limb is much shorter because of this fracture. It can also come through, it can be apparent, so we don't have a fracture, we just have a luxation, dislocation that makes the limb shorter. So, or positional when we have, for example, a contraction of the muscles. And of course, as everything is in medicine, nothing is so simple as it looks. It can be mixed, and then it comes from more things. As I told you again and again, it's very important to understand the function of the patient's locomotor system and understand how we will treat it. But to treat it correctly, we have to diagnose it correctly. Okay? And after we spoke with the patient and seen everything that I discussed, we will use the X-ray. This is the most cost-efficient thing that we can do. It's very, very fast. It's very, very low on price, and it's not very problematic for the patient. The radiations are not so important. Of course, if the X-ray is not enough, for example, if we have a fracture of the calcaneus bone, we have a fracture of the distal part of the tibia, or fractures of spinal cord or something like that, so bones that are three-dimensional, we will use a computer tomography to examine exactly the patient's fracture and to understand how we could treat it best. The next thing that we can do, but not for bones, rather for soft tissue, is the MRI, the magnetic resonance investigation. It gives us a lot of information about, for example, a luxation, a rupture of the cruciate ligaments, why not a malignancy in a lower limb or upper limb. So this MRI helps us see better the soft tissues rather than bone, but computer tomography is much better for bone. Then we will we can do a surgical examination, for example, an arthroscopy that can show us and we can understand much more better the articulation. We can do a biopsy and see if you have an infection, if you have any tumor, something like that, a puncture and stuff like that. Of course, the laboratory examination is very important to understand the patient's other pathologies and see how we can treat them best. And electrodiagnosis that helps us again understand his heart, or why not the contraction of muscle through the nervous system through a electromyography. So there are a lot of things that help us in our diagnosis, but it's also very important to understand the clinical examination, and the discussion with the patient is also very, very important for us because it brings us a lot of information. If you have any questions.
It was clear. Thank you.
Okay. Then if you can stay just 1 minute until I call my superior to see exactly how you will come to the hospital, okay? And I will tell you in 1 minute. I tried to call him, but he doesn't answer, so I'm sorry, but I don't have any information for you right now. But I will speak with Dr. Kursar when he will call you, so he will tell you exactly. I don't think that he will come today. I really don't know right now, but I will tell you in half an hour, something like that, okay?
Okay, thank you so much.
Okay, have a nice day, and we'll see each other tomorrow.
Thank
Bye-bye.
you. Thank you.
Thank
Bye.
you.
Thank you.
Thank you. Have a nice day.
Thank you, you too. Bye-bye.
Thank you.